We have Dr. Rodriguez, and he's doing optimizing sleep with Parkinson's disease.
All right. Okay, good morning. My name is Carlos Rodriguez. I'm a sleep neurologist at the Cleveland Clinic. And today we're going to be talking about sleep and Parkinson's disease. Now, patients with Parkinson's disease are at increased risk for virtually all of the major sleep disorder categories. So there's a lot to cover. Now, of all of the sleep disorders that are associated with Parkinson's disease, the one that is most intimately related to Parkinson's disease is REM sleep behavior disorder. And so that's what the focus of our discussion is going to be for the next half hour. But I'm happy to entertain any questions about all of these other sleep disorders. So with that, REM sleep behavior disorder is a parasomnia. Parasomnias are defined as undesirable physical or experiential phenomena that occur predominantly or exclusively during sleep. And so REM sleep behavior disorder comes out of REM sleep, which is when we're dreaming, okay? So it's considered a REM sleep disorder. And so a word about normal REM sleep before we talk about the disorder. So normal REM sleep, REM stands for rapid eye movement. So when we're dreaming, we get rapid eye movements. Our eyes are closed and they're moving back and forth. And we are paralyzed. And that's normal. And that's good because we can't act out the things that we're dreaming of. Okay? And so when we go into REM sleep, on the bottom here, I have, this thing is called a hypnogram. Okay? And so on the y-axis, the vertical axis, we have the different stages of sleep. So on the top we have awake, and then we have REM, which is those black lines, and then we have non-REM sleep, N1, N2, and N3. And then on the x-axis, on the horizontal axis, we have the time of night. So it starts at midnight, 00, and then 1 o'clock, 2 o'clock, 3 o'clock, 4, 5, and 6. And so what I want you to notice on this hypnogram is that when we sleep, we cycle through all of the stages. And then every 90 minutes or so, we go to REM, which is that black line. And then we go through REM, and then we cycle through the stages again. But each time we cycle through the stages, we get less and less of the slow wave sleep on the bottom, and we get progressively more and more REM sleep, such that statistically, the last half of the night has most of our dreaming because we're getting more and more REM sleep. So that's when most of these things happen, is more towards the last half of the night. And really, this REM behavior disorder should not happen within the first 60 minutes of sleep because we're not in REM yet, right? The first REM happens 90 minutes into sleep. So those are some of the ways that we kind of can recognize if something is coming out of REM sleep. Now, this is a 30-second epic from a sleep study, okay? A 30-second page from a sleep study. And this is what normal REM looks like. And so what I want you to focus on is the red boxes. In those red boxes, that's EMG, that's the muscles. So the chin muscle, and then the right leg and the left leg. And what I want you to notice about those lines in there is that they're very flat. They don't move much. And what that means is that the muscles are quiet. They're not twitching much. They're paralyzed. Okay, so this is what normal REM looks like. Our muscles are unable to contract. Now, this is what REM behavior disorder looks like. And what I want you to look at is in the yellow boxes, you see the chin, and you see the legs, and you also see the arm. And this is all muscle activity. And what I want you to appreciate is that movement in those channels. These are muscles that are contracting. And they're contracting when somebody is dreaming. And so this is somebody who is not paralyzed when they're dreaming. So this is how we diagnose REM behavior disorder, is we do a sleep study and see that the patients are no longer paralyzed while they're dreaming, okay? So on the left, our brain, when a normal person dreams, when we go into REM sleep, we send, there's a message that is sent to all of the nerve cells that go to the muscles. And it turns those nerve cells off. It knocks them out so they can't send a message to the muscle and cause the muscle to contract. So in a person with normal REM sleep, you're paralyzed because your brainstem is actually causing you to be paralyzed. It's an active system, okay? Now on the right, we have a picture of the brainstem of a patient with RBD. And what happens is there is a lesion of this machinery, of this mechanism that makes us paralyzed. So now we can no longer paralyze these muscles. And now you can move while you're dreaming. So this is the basic problem in patients who have REM behavior disorder. So patients with REM behavior disorder, they're typically going to present with sleep-related injury or a potentially injurious behavior. They're acting out a dream. Sometimes it's just, you know, they raised such a ruckus at night. Maybe they didn't do anything dangerous, but they were screaming and hollering, and it was disturbing the family. And that's why they came in. And so we refer to these behaviors as dream enactment behaviors. And the reason is because the behaviors that the partner exhibits, or what the partner witnesses, is a purposeful looking behavior. This person who is asleep looks like they're doing something while they're awake, except their eyes are closed. So it looks purposeful. They might be smoking a fictive cigarette, or they might be, you know, fishing, and stuff like this. So, and classically, when somebody has a REM behavior disorder attack, they wake up quickly from the event, and they're fully with it. They're not confused. They don't remember doing the thing that the partner saw them purposefully, but they do remember doing it in the context of a dream. And they'll tell you what that dream was. And so these events happen no earlier than 90 minutes after falling asleep, because that's the earliest that REM should happen. And most of them, remember, are happening, statistically speaking, in the last half of the night, because that's when most of the dreaming happens. So what are the behaviors that you can see? So people might be arguing, threatening, screaming, crying, swearing, grabbing, flailing their arms, slapping around, punching, kicking, pulling hair, biting, spitting, choking. They might shield themselves from attack because in their dream they're being attacked. Pulling a trigger of a firearm, attempting to set fire to a bed, attempting to leap through a window, jumping, diving, falling out of bed. A lot of times they're just talking. Now talking, all of us sleep talk, or most of us sleep talk. When it's talking, it's usually a little more involved than just saying a few words. They might be delivering a lecture or a speech, or greeting someone, or whistling, gesturing, sitting up, crawling, simulated behaviors like running. So you might see their legs kind of moving alternately like this, back and forth. Small movements, not big ones, but small ones. They can even be positive behaviors, like singing and laughing, or smiling, clapping, dancing. These are all things that patients with RBD do. Now, it's said that a large percentage of patients with RBD have abnormal dreams. 93% reported having unpleasant dreams, where they're being attacked by someone, or they're arguing with someone, or being chased by someone. It doesn't always have to be a negative thing, but a large percentage are. When patients literally eat or literally drink something in their sleep, or urinate or defecate, those are rarely dream enactment behaviors of RBD. They can be seen with RBD, but those are more rare. Getting up and walking around is uncommon. It happens. But, you know, if they leave the room, that is a big red flag for it's probably not RBD. And the reason is patients who are acting out their dreams with RBD have their eyes closed, and they're attending to their dream mentation. They're paying attention to their dream, and they're completely unaware of their environment. And so for them to be able to get out of the room means they probably have their eyes open. That's usually sleepwalking, a different kind of parasomnia. So let's take a look at a couple of examples. Let's see here. There we go. There's no sound. This one's my favorite. It's kind of disturbing, actually. It's easy to see how somebody could get hurt. And these poor souls are not, one of the sad ironies is that these patients, in their dream, they're attempting to protect their partner, but in reality, they're hitting their partner. So the complications of RBD have been very well documented. Bruises, lacerations, patients have dislocated shoulders, chipped teeth, fractured all sorts of bones. There's a couple of cases of patients who dove out of bed and sustained hemorrhages in their brain. So this is a picture of a poor lady who did that. She didn't have a subdural hemorrhage, but she did in fact, chip her teeth and had this battle sign, or these two black eyes. So if there was only one thing that I could convey to you today, maybe this is the most important one, and that is that RBD is very commonly undiagnosed. And so it's very important that if you or your partner, if you've seen these types of behaviors, you have to tell the provider, because the provider won't know. And a lot of times folks don't mention this because there hasn't been a bad effect from it. There hasn't been an injury, but there's always the first injury that takes place, and it may not happen at the get-go. There was a study that was conducted in 2018 where they evaluated 203 people with RBD, and 44% of those patients were unaware that they were acting out their dreams. And 70% of those patients said, my sleep is good, there's nothing wrong with me. So this is oftentimes a disorder that it's the partner that brings it to light because the patient simply doesn't know. If you look at the general population, 1% of patients get RBD. But in patients with Parkinson's disease, it's much higher, and I'll show you that figure. This disorder was long considered a male-predominant disorder, so it's mostly happening in men. But more recent studies have demonstrated that women get this just as much. And the reason that women had not been recognized to have it is the nature of their dreams. So the women aren't as violent. And so then it's less of a problem if they're smiling or dancing. Or I remember there was this one patient who was, with a pot, and she was mixing the pot. Those sorts of things don't command a lot of concern, but it's still REM behavior disorder. And most commonly, this is going to present in people who are more than 50 years of age. Risk factors have been identified: smoking, head injury, pesticide exposure, farming. Another study found smoking also, fewer years of education, traumatic brain injury, welding work, pesticide exposure. Now, RBD is very closely related to the synucleinopathies. The synucleinopathies are a group of neurodegenerative disorders that share a common pathologic lesion on biopsy. And for all of them, they're accumulating this substance called alpha-synuclein, which is a normal substance, but it's accumulating for some reason in these brain cells and in the supporting cells in the brain, the glia. And so there are three major synucleinopathies. There is Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy. And so remember, for the prevalence in the general population is 1% of the population gets RBD. But if you just look in Parkinson's disease, 46% have RBD. If you look at dementia with Lewy bodies, it's 50%. And if you look at multiple system atrophy, another one of the synucleinopathies, it's 100%. So the way we diagnose this is patients have to have a history of repeated episodes of sleep-related vocalization and other complex movements during their sleep. And then they have to have a sleep study that shows that they're not paralyzed while they're dreaming. And so we do a polysomnogram, a sleep study, one, to rule out mimickers. There are other things that look just like RBD. And so we want to make sure, for example, that they don't have sleep apnea. So sleep apnea can look just like RBD. So what is sleep apnea? It's a condition where people are having repetitive episodes of partial or complete upper airway obstruction. So the airway is collapsing while you're asleep. And the air can't get through, and so the oxygen levels fall. They snore, and they're sleepy during the day. And so there is this thing called pseudo-RBD, which is sleep apnea, that is mimicking RBD, but it's not RBD. And so these people are having respiratory events. They're stopping breathing while they're dreaming. And then they wake up, and they throw the punch or whatever it was they were doing in their dream. So it can look the same. And patients who have pseudo-RBD, that is sleep apnea, when you treat them with CPAP, it goes away. The second reason we do a sleep study is to diagnose the RBD, to show the REM sleep without the dreaming. And so this is a 30-second epic of a normal sleep study. And again, you see the same red boxes, and you see that the muscle tone is flat. There's no muscle activity. Now, the problem is, this is a standard montage for sleep apnea. This is how we do a sleep apnea test. But this patient actually has RBD. So you can't do any sleep study. You got to do a sleep study that's looking specifically for RBD, which means you have to include the arms, muscles in the arms, which are not done at any sleep lab unless you're looking for RBD. So now I'm going to go to the next page, and this is the same page, okay? But I just added the arms in the yellow. And you notice that the arms in the yellow box, there's increased muscle tone. So sometimes people only show us the REM without atonia in the arms. So you can't just get any sleep study. You got to get a sleep study that's tailored to evaluate for RBD. And labs don't do this because it's burdensome. It's a lot of effort. So how do we treat patients with RBD? The most important thing is safety measures. So lower the bed mattress. In case you fall out of bed, you're less likely to hurt yourself. Sharp furniture should be moved away. The edges should be padded. A soft carpet or a rug mat placed next to the bed, or a cushion in case you fall out of bed. You want to make sure there's no firearms or any objects that could be used to inflict injury. I had a patient discharge a firearm. Fortunately, nobody got hurt. For severe uncontrolled RBD, the bed partner ought to sleep somewhere else, or at least you ought to try to erect some kind of barricade between the partner and the patient so they don't get hurt. There are medications that can be used to control the RBD. My favorite is melatonin. But there's also pramipexole, which is Mirapex, which some of you may be familiar with. Rivastigmine patch, which is a medication that was designed really for Alzheimer's. And then clonazepam is another medication that can be used. There's also a customized bed alarm that you can purchase. So it's got, a little sensing pad underneath the patient's shoulders, or it's tethered. The patient is tethered to has a tethered cord attached to them. And so if they move, this thing will get discharged. It'll recognize that this person is acting out a dream. And then a pre-recorded message is given by a loved one, giving them a reassuring message. Hey, it's just a dream, don't worry, go back to sleep. And sometimes that's all it takes to be able to get one of these events to stop. So my take-home messages for you today are, one, it's important. The most important things are, one, if you're a bed partner, you've got to make sure to tell the provider, the medical provider. And then two, if there's any purposeful appearing behaviors during the sleep. And then two, the only way to diagnose RBD, and this is the only parasomnia that requires a sleep study, the only one that requires a sleep study, you got to do a sleep study to make the diagnosis of RBD. You can't do it just by history. And if you do a standard sleep study, you got to make sure you go to a lab that does the specialized testing, because so our lab at main campus does this, okay? And all the Cleveland Clinic surrounding labs. But I don't know of another lab that does this routinely. So I'm going to stop here. I'm sorry I went a little bit over. I'll make myself available for any questions that you may have. Thank you.